Good morning. I am Dr. Nisraj from Pharmacology. Today we will be talking about the drugs for peripheral vascular disorder. When we talk about the peripheral vascular disorder, we are talking about blood vessels, that is veins and arteries. Veins are mostly the surgical problems like varicose veins. So here we will be talking about the vascular disorders which can be managed by some drugs. So we will be specifically talking about the peripheral artery disease. Peripheral artery disease is a clinical disorder in which there is stenosis or occlusion or obstruction in the aorta or in the arteries of the limbs. Atherosclerosis, the pathological condition, is the leading cause of peripheral artery disease in patients who are above 45 years. The other causes of the peripheral artery disease are thrombosis, that means the clot formation in the vascular system; embolism, that means a part of the thrombus is broken and circulates in the blood and gets entrapped in the arteries; vasculitis means there is some inflammation of the arterial system in the endothelium; or there is some fibromuscular dysplasia. The fibromuscular tissue of the artery is having some pathology; or there is some entrapment. Entrapment means that the artery is passing through the bony or hard prominences and it is blocked or compressed by other structures so that the blood cannot flow. Then cystic adventitial disease, that is some cyst formation around the adventitia of the arteries; and trauma, that there is some accident or there is some injury, so the artery is blocked or damaged, so there is no blood supply to the proximal organ. The highest prevalence of the atherosclerotic peripheral artery disease occurs in the 6th and 7th decade of life. There is increased risk of developing peripheral artery disease in the smokers and in persons with diabetes mellitus, hypercholesterolemia and hypertension. In smokers, there is damage to the endothelial lining of the blood vessel and there is some inflammatory reaction. There is some thromboangiitis, that is thrombus formation, vascular inflammation and obstruction. That is also called the thromboangiitis obliterans. In diabetes, there is deposition of the cholesterol and other metabolites in the arterial wall and that causes the atherosclerosis. In hypercholesterolemia, the cholesterol is high, there is deposition of cholesterol in the arterial wall and then there is a inflammatory reaction. Then hypertension, there is arteriosclerosis. The continuous hypertension causes some damage to the retina and the arteries. Then renal insufficiency, there are some cardiovascular changes in renal insufficiency like angiotensin system comes into the play and there could be hypertension, so that causes the arterial disease. Now the pathology of the arterial disease, as you see here, that the block occurs somewhere in the legs, in these parts. There is cholesterol deposition and damage to the internal vascular system. There is a cholesterol streak on the arterial wall Then there is deposition of fat because some monocytes and phagocytes come and they ingest the fat and then there is some adhesion of the platelets, then inflammatory reaction, then there could be some tearing of this part and the thrombus formation and thromboembolic phenomena. Here you can see that in this section there is deposition of cholesterol and fat, and there is this membrane, fibromuscular membrane, which is obstructing the flow of the blood through the artery. So atherosclerosis is a slow and progressive building of plaque in fatty substances, cholesterol, cell waste products, and there is some calcium deposition also there because there is some continuous inflammatory reaction. So these type of pathologies cause stenosis or occlusion of the localized artery and medium side vessels. The lesions are atherosclerotic plaques with calcium deposition. There is thinning of media and patchy destruction of the muscles and elastic fibers, and that can lead to the fragmentation of the internal elastic lamina, and thrombus formation occurs because the platelet adhesion and fibrin deposition. The primary site of the involvement are abdominal aorta. In 30% cases, iliac arteries are involved, and in 90% of the cases, the femoral and popliteal arteries are involved. And in 50% of the cases, peroneal tibial arteries are involved. Here you can see the femoral pulse site, dorsalis pedis. So when there is obstruction here, you will feel the pulses here, which are just minimal. Similarly, if there is obstruction is here, if you feel the pulse here, it will be very minimal because of the obstruction. The atherosclerotic lesions occur preferentially at the arterial branch points. That is where the artery is dividing, like this. Where the artery is dividing, there is turbulence in the blood flow and causes the deposition, cholesterol, and intimal injury. The The involvement of distal vasculature is most common in elderly patients with diabetes mellitus. Then comes the clinical evaluation. In clinical evaluation, the patient often complains about the pain, that is called intermittent claudication, that the person walks for some distance and he develops a well-defined pain in the muscles. He feels fatigue and he wants to take rest. So this is because of the lack of blood supply and lack of oxygen, nutrients, and development of carbon dioxide and inflammatory reaction in the muscles and pain. The patients often complain of rest pain in severe conditions, but there could be some numbness because the nerves also are involved, and there could be injuries to foot and toes or upper limb, thumb. Frequently these symptoms occur at night when the legs are horizontal and improve when the legs are in dependent position. So when the leg is in dependent position, there is some blood supply to that part, but when it is horizontal or raised, the blood supply is lower, so pain is felt. feeling of pain is more. In severe ischemia, when there is very minimal blood supply, then pain can develop on rest also. The important findings of the peripheral artery disease include decreased or absent pulses distal to the obstruction. So if there is obstruction in the femoral, then in the lower part of the limb there will be no pulse or minimal pulse. So when you put your stethoscope on the place of obstruction or distal to the place of the obstruction, there could be some turbulence of the blood flow, and that sound can be heard on the stethoscope. That is called bruit. So if there is severe ischemia of the limb, there could be, as you see here, there is hyperemia, redness, swelling because of their ischemia. There is hypoxia, release of inflammatory uh, inflammatory cytokines or prostaglandins or other things. Then there is inflammatory reaction. Then there could be degeneration. If the obstruction continues, then there could be necrosis, and after that there could be gangrene, and this could be dry gangrene or wet gangrene, or if it is infected there could be gas formation. And so this, you see the blackening part, this is the gangrene and this is the inflammatory reaction which is occurring. So in patients with critical limb ischemia, ulcers can develop. This can be ulcerated. The elevation of the legs and repeated flexing of calf muscles produce pallor of the soles of the feet. So if there is minimum blood supply to the part, then if you elevate the leg or the limb, the blood supply will be lower, so that there will be pallor formation. So, and when the legs are dependent, the person is standing, then there could be some hyperemia because there is some increase in blood flow to that part. So these are the tests and clinical evaluation. In patients with ischemia, there could be some edema formation. As I told you, there could be some hyperemia, inflammatory reaction, and edema formation can occur. And also because they keep the legs in the dependent position, so there is a edema formation. Ischemic neuropathy can result in numbness and hyporeflexia because the blood supply is lower, so neuropathy, neurons of that part are damaged, so there could be numbness, lack of feeling of the sensations, and there could be hyporeflexia. So these patients who are having peripheral artery disease should receive therapies to reduce the risk of associated cardiovascular disease. These patients may be having some cardiac problem like myocardial infarction and hypertension or diabetes associated with this, that treatment is also required. The risk factor modification of smoking, alcohol, and antiplatelet therapy should be initiated to improve the cardiovascular outcomes in these patients. It is important to control blood pressure, hypertension, or diabetes mellitus in these patients. The angiotensin converting enzyme inhibitors may reduce the risk of cardiovascular events in patients. So because, as you know, the angiotensin causes the vasospasm and narrowing of the vascular system, arteries. So if you just block the angiotensin or inhibit the synthesis of angiotensin 2, then this can have some beneficial effect on this condition. The treatment of hypercholesterolemia should be initiated with statins to reduce the cholesterol synthesis in the body so that less cholesterol is deposited on the arterial walls and less the condition of myocardial infarction, stroke will occur in these patients. The platelet inhibitors can be used just to prevent the thrombus formation and clotting. And aspirin, clopidogrel can reduce the risk of adverse cardiovascular events in these patients who are also having atherosclerosis. The antiplatelet therapy with aspirin and clopidogrel when combined is not more effective than aspirin because the maximum of platelet inhibition has already occurred. So if you add another drug, that doesn't make any much difference. So only one type of drug can be used. Moreover, the more side effects can occur if you increase the dose or give the combination of the drugs. The mortality and morbidity can increase with this if you give the two drugs. The anticoagulant warfarin is effective to prevent clotting, but the side effects should be monitored in this patient. The therapy for intermittent claudication and critical limb ischemia should include the supportive measures, medication, non-operative intervention, and surgery. The supportive measures include the meticulous care of the feet because there is a ischemia, there is some degenerative changes, hyperemia, or numbness. So the part should be taken care of. It should be kept clean to prevent infection. It be protected against excessive drying with moisturizing cream, or it should be protected with shoes so that there is no trauma to that part. Now we talk about the drugs for peripheral vascular disease. As we talked earlier that the peripheral vascular disease, there is a occlusion of the blood vessel like in Buerger's disease. So there is vasospasm. In Raynaud's phenomenon, there is spasm of the arterial radial artery, and there is blanching and cyanosis of the fingers followed by hyperemia, or both conditions can coexist like atherosclerosis and diabetes, and there could be some hormonal disturbances also in this patient. There could be associated cerebrovascular inadequacy because there is vasospasm, lack of the blood supply to the brain and to other organs in the body. So cardiovascular risk is always associated with the peripheral vascular disease, peripheral artery disease. So then the measures that reduce the cardiovascular risk are the smoking cessation. The person should stop smoking, and blood pressure should be controlled. Anticoagulant drugs should be given to prevent the platelet aggregation, and diabetes should be controlled to control the metabolic disturbances. Statins should be given to reduce the synthesis of cholesterol, and the weight should be reduced. It is known that the obesity is the cause of many types of cardiovascular problems. So weight should be reduced in this patient, and exercise should be advised so that metabolism becomes faster. However, efficacy in peripheral disease is slightly different from placebo. So, as you know, placebo is just inert medicine. So there is a slight difference. there could be some better improvement if you give the treatments for this. So for that, the dose of the cyclospasmol is given 200 to 400 milligram TDS. There is something wrong. The cyclin delete, it is a papain-like drug which causes the relaxation of smooth muscle in the arterial vessels, and that increases the cutaneous skeletal muscle and cranial blood flow in the normal individuals. So cyclospasmol is given at 200 milligram to 400 milligram 3 times a day. Then other drug is xanthinol nicotinate. Xanthinol nicotinate is a compound of xanthin and nicotinic acid, both of which, there is some problem in scrolling. So it is a vasodilator, it increases the blood flow in many vascular beds and has been promoted for cerebrovascular or peripheral vascular disease, but its therapeutic benefit is just minimal. Dose is 300 to 600 milligram 3 times a day. 300 milligram injection can be given, or slow IV injection can be given. It is available in the form of Complamina 150 milligram tablet and 300 milligram per 2 ml injection available. Then the other drug is pentoxifylline, oxypentyphylline. It is the analog of theophylline and weak phosphodiesterase inhibitor. It has been shown to increase blood flow in ischemic areas by reducing whole blood viscosity and improving flexibility of RBCs. So it is thought to uh, reduce the viscosity of the blood by improving the flexibility of the RBCs. The rheological property of flow action is responsible for improving passage of blood through the microcirculation. So this can improve some circulation of RBCs through the ischemic areas. And because this is occurring not through the vasodilation, so steal phenomena is not likely. Oral doses of this drug do not affect the heart rate or blood pressure, and pentoxifylline is usually well tolerated. Side effects are nausea, vomiting, dyspepsia, and bloating, which can be the side effect of the pentoxifylline are nausea, vomiting, dyspepsia, and bloating, which can be minimized by taking the drugs after meals. The dose is given as 400 milligram twice a day or thrice a day. And some slow reacting, slow release tablets are available, and that can be given for a longer time of action. Pentoxifylline is mainly used in intermittent claudication, that is the presence of pain in the calf muscles while walking, and the walking distance is increased by taking this drug. The person was having pain after walking for uh, 500 meters. Now he may walk for 1 kilometer without pain. Other conditions claimed to be improved are the trophic leg ulcers, because there is some improvement in the blood supply. So the ulceration and ischemic, transient ischemic attacks, or non-hemorrhagic stroke, or chronic cerebrovascular insufficiency may be improved. The overall benefits are modest, and they are limited to some patients who are having minimal cardiovascular involvement. Then other drug is silostazole. This is a phosphodiesterase 3 inhibitor which increases the intracellular cyclic AMP in platelets and vascular smooth muscles, that results in the vasodilation and inhibition of the platelet aggregation. That is anti-aggregatory effect and vasodilatory effect of the drug. In clinical trials, it has increased walking distance in patients with intermittent claudication and appears to be more effective than pentoxifylline. So, it appears to be more effective than pentoxifylline. So that is the important to note. However, there is no increase in the cardiovascular mortality with the silostazole, but warning has been issued not to use silostazole in patients with heart failure. So if the patient is having heart failure, he should not be given silostazole. It is a warning. And it should not be given in the patient who have severe ischemia, like they have pain at rest. So there is severe ischemia and tissue necrosis. So in those conditions, the drug may not be effective because it is causing vasodilatation. So vasodilation cannot occur because there is already sufficient ischemia and necrosis, and the blood flow is not there, so anti-aggregatory effect also will not be effective. The most common side effects are headache, palpitation, dizziness, nausea, vomiting, weakness, and increase in ventricular ectopics. Silostazole is extensively metabolized by cytochrome P enzymes, and its half-life is 12 hours. It should not be administered with the inhibitors of these enzymes. So if these enzymes, cytochrome P type enzymes, are inhibited, then the metabolism of this silostazole will be inhibited and the side effects will be more. So the combination of this type of drug can increase the toxicity of this drug. So silostazole is indicated for intermittent claudication in patients who are having minimal rest pain. with no breast pain. Then in severe disease it may not be effective, and it should not be given in heart failure. It is a warning. So the dose is 100 milligram twice a day, 30 minutes before or 2 hours after food. So food may interfere with the absorption of the drug. So it should be given before food or after 2 hours after food. Other drug is adrenergic agonist isoxsuprine, which can be tried but not proved. Calcium channel blockers like nifedipine and alpha blockers like prazosin, phenoxybenzamine have been used in peripheral vasculitis, but this type of therapy may not be effective in this condition because there is disturbance, already there is some disturbance, and the drug cannot produce more vasodilation by using that. Because ischemia itself is most potent vasodilator. In ischemia there is hypoxia, uh, retention of the carbon dioxide and other metabolites, and that causes the vasodilation of that place. So if you give more vasodilators, that may not be effective. Moreover, the vasodilators can divert the blood to non-ischemic areas. The blood vessels which are normal will be dilated and more blood will be circulated to the dilated areas, and less blood will be going to the ischemic areas because there is already blockage of the artery. So this can cause a steal phenomena. The condition may be aggravated rather than improved. So one has to be careful about using vasodilators. So when there is vasospasm, like in Raynaud's phenomena, there is vasospasm. The old woman is putting her hand into the cold water and there is vasospasm in the radial artery and having pain in the hand. Then in those conditions when there is vasospasm, the drugs which can reduce the vasospasm or vasodilator can be helpful. So there is one drug called prostaglandin I2. It is a vasodilator and can be used in cases with severe pain because of the peripheral vascular disease. So these are the drugs which we can use in the peripheral arterial disorders. Then in extreme cases there is surgical intervention, like if there is gangrene or necrosis of the part that has to be removed surgically, and if there is some infection has to be treated, or one can pass a balloon into the artery and this part can be dilated to allow the blood to flow through this, or there is some stent can be put into that area by use of catheters. These are the surgical interventions which can be done and beyond the scope of pharmacology. And this ends the lecture of today. It was a short lecture by involving clinical information. I had tried to expand this lecture, but it is a very short lecture. So here I finish this lecture. Thank you very much for your patience and cooperation. Okay.